Let's talk about this terminology that I believe I've coined because I really haven't seen it in the literature. I call it spinal augmentation. We know about vertebral augmentation, which we consider vertebroplasty or kyphoplasty, when you put cement into the vertebral body to stabilize a fracture. But when I look into the literature about spinal augmentation, I haven't really seen this. And let me give you a background on what my concept of spinal augmentation is. Augmentation means to add something. So you're adding something to the spine. And when you add something to the spine, it could be different substances, and we'll go into each of these different individual substances that we're going to add to the spine to relieve pain and inflammation, improve circulation, and get patient more functional. So let's talk about why I consider spinal augmentation important. If you look at the history of how we've treated spinal disorders, going back 15 years, not even go back 20 years, let's go back 15 years. At that point, most insurances, Medicare and most insurances, would allow you to do what you felt was medically necessary. Meaning that if you felt that a patient had 2, 3, 4, 5 levels of spinal disease that's contributing to the pain based upon the clinical symptoms, examination, and MRI and CAT scan findings, when you put it all together, you can go ahead and treat that patient. So I can do what you would call a 1, 2, 3, 4, up to even 5 levels of spinal injection to treat pain that's related to impingement of the nerve root. Even many years ago, you can also add and treat facet disease by injecting the facet joints, the nerve, the medial branch, and the joints to help patients with pain. In my years of experience, I found that has been the most helpful way of relieving pain. I must let you know that I am a clinician. I'm not a scientist in the sense of I don't do scientific studies and research in the lab. I treat patients. I treat my patients clinically based upon what I find on their history and the examination. And the number one goal is to get the patient out of pain and functional. And that means that you may have to do more than one treatment in more than one area. So basically what we are dealt with at this point is that workman's comp and now Medicare and insurances are only allowing physicians to treat 2 levels of the spine at a time. So 15 years ago, if you had problems at 5 levels on both sides, I can treat all 5 levels at a time. Now, I can only treat 2 levels at a time based upon the insurance company's guidelines, where you inject 2 levels and they come back a week later. You do 2 levels, you come back a week later, you do 2 levels, and you come back a week later, you do 2 more levels. And they actually give you a limitation of how many you can do within a 12-month period of time. You can only do 12 levels. So the patient has to get better with those injections, otherwise it's considered a failure. Well, this is 23 years of doing this and taking care of patients. And my opinion is that you have to do more than that, because not everyone fits that cookie cut treatment of 2 levels at a time. And patients have to come back and forth for treatment. So my concept of doing diagnostic injections and also comprehensive treatment is based upon my experience of where I did diagnostic facet blocks, where you block the facet medial branch. And I actually believe that in elderly patients, the joints which have arthritis causes back pain. How can you say that your finger joint, your knee joint, your elbow joint has arthritis, causes pain, but the spinal facets, which has arthritis, which is quite obvious on the imaging studies, on examination, doesn't cause pain? So if you only block the medial branch, in my opinion, and you don't treat the arthritic joints, you may get an incomplete pain relief. So I treat everything as a whole if I see and I know that there is disease process going on at those levels.